Okay, I'd like to thank Dr. Rolly de la Cruz for inviting me to speak in this webinar amidst a group of very distinguished surgeons. My topic is actually about discussions on the pathophysiology and management of bleeding in cardiac and vascular trauma. So let's start off with a case of a 41-year-old male with a stab wound to the left chest wall, midclavicular line just below the nipple, was transported to the nearest hospital. He's a prisoner in one of the prisons here in Manila. So in 90% of cardiac surgery trauma, these patients die before they get to the hospital. When you see this type of someone like this, it's a rare opportunity. And this is an actual patient with like a nail sticking out on his left chest wall. Well, in the Philippines, like what I saw with Dr. Gupta, the data and the studies are still a bit lacking, but I was able to tally some vascular injuries seen in our institution from 2015 to 2020. As you can see, 82% of patients are males, while around 18% are females. There's a predominance of penetrating injury at 90.4%, with only 9.6% of patients with blunt injuries. Most of the surgical repair done in these patients at our institution are primary, which includes arteriography, venorrhaphy, and end-to-end anastomosis. This graph shows another primary outcome, which is mortality, and overall mortality is about 9.6%, with most of the patients dying because of penetrating mechanism. Most commonly involved region of these patients is the central, specifically the IVC at 31.6%. These patients have multiple organ involvement and massive blood loss. Lastly, for the secondary outcome, we computed for the average length of stay. There's a lot more in blunt injuries, probably because more observation being done. This is the ATLS way of trauma management. I think all of you know this. This used to be the ABCDs of trauma, starting with the airway, breathing, circulation, and disability. But is there a shift from ABCs to CAB? Why CAB? In the hemorrhaging patient, the patient is physiologically trying to keep himself alive by the adrenergic response to bleeding, the gasping, and the vasoconstriction. And when we do airway, first we start giving the patient sedatives, paralytics, and positive airway ventilation. And this actually, vasoconstriction is less after this. Cardiac output is less because of the less gasping. The IVC might be compressed by positive airway ventilation. Then you have hypotension, and this patient just might go into cardiovascular arrest. So right now, we prioritize perfusion over airway in the bleeding patient. This is the American College of Surgeons definition of classes of acute hemorrhage. The normal circulating blood is about 5 liters, and class 1 has blood loss of less than 15%, so which is around 750. Class 2 is about 15 to 30%, or 750 ml to 1,500. Class 3 is 30 to 40%, around 1,500 to 2,000, and the decrease in blood pressure and increase in heart rate above 120. Class 4 is greater than 40% of or greater than 2,000 ml with profound effect on parameters shown. So what is the pathophysiology of shock? Actually, it's just inadequate tissue perfusion of oxygen. Then there's a switch from aerobic to anaerobic metabolism, lactic acid production, cell function becomes deranged, membranes become permeable, electrolytes and fluid leak out of the cell. Sodium potassium pump are impaired, and there's mitochondrial damage and cell death occurs. So these stages of shock, initially there's hypoperfusion, hypoxia, anaerobic metabolism, and lactic acid buildup. Then compensatory physiologic mechanisms try to reverse this. Then there is a progressive stage wherein these mechanisms start to fail. And lastly, refractory, where the organs have failed and they cannot be reversed. So hemorrhagic shocks about 30 to 40% of all fatalities, secondary only to brain injury as a cause of death in trauma. When you have reduction of blood volume, you have interruption of O2 delivery and accumulation of toxic metabolites. There is an increase in lactic acid, oxygen-free radicals, and inorganic phosphates. There is a continued decrease in ATP because of the shift from anaerobic metabolism, failure of cellular hemostasis, cell death through necrosis by membrane rupture, apoptosis. Then you have adaptive and maladaptive changes, which happen because of the clotting cascade, where hemostatic plug and fibrinolytic activity increases and prevents microvascular thrombosis. Too much crystalloids actually dilutes O2 carrying capacity and clotting factors. Cold fluid infusion worsens heat loss and worsens acidosis. There's a vicious cycle because of the shift in anaerobic metabolism causing increased lactic acidosis, which depresses myocardial function, causing hypothermia and decreased blood clotting, which causes increased acidosis. So this is a vicious cycle and trauma triad of death. Well, this is the classes of hemorrhage again with the treatment plan at the bottom. For class 1, class 2, you give crystalloid, which may suffice, but in class 3 and 4, you may have to give blood as well. This is a response to initial fluid resuscitation. With the type of blood preparation needed for rapid response, the best would be to give typed, specific, and cross-matched blood. For transient response, you give type-specific blood. For those with minimal or no response at all, you give emergency type O release. So what is damage control resuscitation? It is a systemic approach to management of the trauma patient with severe injuries, which starts in the ER and goes through the OR and then into the ICU. It includes early blood transfusion, permissive hypotension when appropriate, control of ongoing bleeding, damage control, surgery, and post-resuscitation phase. Crystalloids remain the standard fluid of choice, and colloids increase the risk of death. Now, massive transfusion protocols are standards of care in major trauma centers, but the ratio of packed RBC, FFPs, and platelets vary within these institutions. Massive blood transfusion protocols are started if there's more than 10 units of packed RBC is given within 24 hours, or 4-unit packed RBC is given in an hour with anticipation of to give in the next 24 hours. FFP and platelets are not used in the calculation. So the recommended ratio is 1:1:1. I'm sure you know this. RBCs 1, plasma 1, and platelets 1. There's now an ABC score assessment for blood consumption score made by the Vanderbilt University, which has a very high specificity and sensitivity rate, wherein the assessment of blood consumption, it has a pulse of, if you have pulse of 120 beats per minute, systolic blood pressure of less than 90, positive fast or focused assessment with ultrasound in trauma, and a penetrating torso injury, you consider the 1 each as an assigned 1 point, and a score of 2 or greater should trigger the massive transfusion protocol activation. Fresh whole blood transfusion may now have more effectiveness than some of its parts, because component blood storage has degradation of effectiveness over time and decreased 2,3 DPG activity and decreased factor activity. These are samples of massive transfusion protocols where uncross-matched blood will be ready in just 5 to 10 minutes. A little more than that is type-specific blood, and then cross-matched blood in about 45 to 60 minutes. Or the electrolytes and coags are determined as well. Here's still another MTP protocol with different blood product packs and protocols on transfusion and replacement. Now, one is permissive hypotension. It's actually shock that requires surgery, and it has shown no difference in mortality, though less fluid requirement and less coagulopathy, and lower INRs have been seen. Aggressive fluid resuscitation actually dislodges a clot. So a limited resuscitation tolerating a MAP of about 50 or a palpable radial pulse is maintained. So newer studies actually do this until bleeding is controlled, and they try to limit it in about an hour with this British military paper. Neutrophil, these organ perfusion, like very important, especially the sensitivity to ischemia, like the brain and the heart. These are very, very sensitive to hypoperfusion. Kidneys are somewhat better, but can turn sour quite quickly, as in many post-op cardiac surgery patients with prolonged ischemic time. Though muscles can tolerate ischemia way better, and they can regenerate after injury. So how can you do controlled bleeding by doing damage control surgery? It's just by putting your finger on top of a bleeding site. Like this one is just put your finger on it. You can temporarily put some vascular shunts on. Just do vessel ligation. You can place abdominal packs and close using any of the following. You can tamponade using inflating or using balloons and catheters. Place negative pressure if tissues are still swollen that you cannot close as of yet, and like so. And then a Reboa. You can place a balloon catheter, column femoral, up to the proximal part of the descending aorta to try to stop major bleeding distal to this. Will be discussed extensively by the other speakers. My experience in this is mostly on aneurysms in the abdominal aorta. We put a Reboa catheter, or we could put even just a Foley catheter in. So now we go to the post-resuscitation phase. Where it's a period where coagulopathy is corrected and microcirculatory flow is improved, and hemodynamic parameters are stabilized, and generally we often use a target of about maybe 65 millimeters mercury. Now, correction of electrolytes are done. And, vasopressor therapy is not usually used because of the fact that it could actually lead to more hypoperfusion because of vasoconstriction. But these are the agents that you can use. So let's talk about tranexamic acid. Mechanism of action is actually it binds to plasmin, making it inactive to remove the fibrin. And then this is a crash to trial that studied the role of tranexamic acid in trauma with significant hemorrhage. And using about 20,000 plus adult trauma patients in 274 hospitals in 40 different countries, the conclusion is a 10% relative risk reduction in mortality if administered within 3 hours of injury. The recommendations are for adult trauma patients over 16 years old, ongoing or significant hemorrhage, blood pressure of less than 90 or heart rate 110. Infusion started within 3 hours, and but we have to be aware of effects which is probably because of thromboembolism or thrombosis, such as PE, DVT, MIs, CVA, renal cortical stenosis, and some eye problems. Now, they're actually recommending approach to tranexamic acid use, a selective approach, such as these papers, the military application of tranexamic acid. Another one from the Journal of Trauma, Acute Care Surgery, and this one as well by Moore et al. So how can we actually be selective, be more selective? Well, we could get a thromboelastogram, which actually measures all phases of hemostasis in the whole blood, namely the initiation of clot on the line there, and then the amplification, the mid part, and the fibrinolysis, which is the end part there. And these are the TEG tracings, or where you can just follow the treatment algorithm on the right side, where just to give FFP, cryoprecipitate, or even just tranexamic acid, for example, because they found out that only about 18% would actually benefit from giving tranexamic acid through this means of assessment. Monitoring, we put in a blood BP cuff, arterial line, ECG, and all. We could use a esophageal Doppler to determine aortic flow. Transesophageal echocardiography could be seen for fluid assessment just by looking at the chambers, and the IVC, which this we do in cardiac surgery. And then we could actually use the flow track, Vigileo, or ClearSight monitoring device. It measures cardiac output. Okay, so let's go back to our case initially. So our impression is to stab wound on the left anterior chest, rule out cardiac injury. So the patient became hypotensive, AT palpatory, heart rate 130s, RR of 30s at the ER, and 2 large bore IV lines were inserted, and fluid resuscitation was done, and blood products were secured. This stab wound was actually inside the cardiac box, which is bounded by the clavicles on the top, the nipples laterally, and costal margins inferiorly. So what would you do? Would you do an ED thoracotomy? Well, this is actually would be useful for hemorrhage control, a release of cardiac tamponade, be able to do open cardiac massage, prevent air embolism, exposing the descending aorta for cross clamping and repair of cardiac or pulmonary injury. These are protocols for trauma where you can do ED thoracotomy once the patient is found in profound refractory shock or during CPR. And then this is another trauma protocol. When the patient is in arrest, you can ensure that you're penetrating thoracic or cardiac injury. For tamponade, you could do ED thoracotomy. However, see at this graph, it shows that on the blue line, when there's less ED thoracotomies done, the better the survival is on the the orange line. So is this because of you know, a Reboa or something? I'm not so sure. When you do the EV thoracotomy, this is how you do it. You just incise in the lower, below the nipple line, identify the phrenic nerve and pericardial sac, where you open. You retract the lung and identify the thoracic aorta, where you clamp to improve the perfusion to the coronaries and the brain. Make your incision anterior to the phrenic nerve to access the heart. So you can even do a clamshell incision by cutting across the sternum to access the contralateral side and great vessels. And then you could actually control the bleeders or do open cardiac massage at this point. And you can control bleeders by using felted U-stitches or even buttressing opposing segments together. I usually use Prolene sutures for this and soft felt. So let's go back to our case. During simultaneous fluid resuscitation, we did open median sternotomy, open the pericardium to relieve the tamponade, suctioned out all the clots, and the patient became more hemodynamically stable. So we placed a purse string suture or felted sutures around the nail before removing it to get good hemostasis before pulling it out. So this is the nail. In conclusion, take-home points for this is, you know, hemorrhagic shock should be treated early, as Dr. Gupta said. Prioritize circulation now. No damage control. Resuscitation includes permissive hypotension, prompt control of bleeding, and coagulation. Activate massive transfusion protocols when needed. And tranexamic acid within 3 hours of injury, or better if selected approach is done. So thank you for your attention.